Dr. Tufan Pati sir. Sir has been leading the program since the inception. Sir, over to you for your comments and take over the show.
Thank you, Dr. Alim. Thank you for the kind introduction. Next slide, please. We will be going directly into the program and discussions we'll keep at the end. We have got vibrant moderators in our program. From the very outset, Dr. Amrit Patajoshi and Dr. Alim Siddiqui. And we are also enriched by the presence of Dr. Vishal Chabra. This next slide, please. Dr. Vishal Chabra. Next slide, please. And Dr. Shobit Garg. Welcome all the moderators. And I have the pleasure and privilege to introduce our chairpersons. Dr. Akhil Agrawal, MBBS DNB, FIPS Mental and Sexual Health Consultant, Speaker, Relationship Guide, Entrepreneur and Trainer. Journal Secretary of IM Rajasthan, Past Secretary of IMA Kota, Best Sexologist Healthcare Award by Dainik Bhaskar, Young Entrepreneur Icons Healthcare Award by Times of India, 2018. Dr. IRS Reddy National Award for Excellence in 16th ANSHIAP 2014 at Khajuraho. Dr. Amit Vora National Award of Excellence in 11th ANSHIAP 2010 at Jammu. Awarded by WHO for Excellence in Projects, PSBS 2007, Rajkot. Multiple district awards for promotion of sexual and mental health. With this, I have the privilege to welcome Dr. Akhil Agrawal. Next, please.
Thank you, sir. Thank you very much.
Next slide, please. Alim. Yeah. Dr. Subhendu Misra from Bhubaneswar, Odisha, is the other chairperson. He is affiliation President IPS Odisha State Branch, co-chairperson in Sports Subcommittee and nominated by IPS 2024. Ex-Assistant General Secretary of IPS Odisha, immediate first General Secretary of IPS Odisha, member Indian Association of Private Secretary, life member of International Association of Sexual Medicine Practitioners, IASMP, life fellow of Indian Association of Child and Adolescent Mental Health, IASM. More than 20 publications in national and international journals, more than 200 newspaper articles, and many mass media programs for mental health awareness, including TV shows, FM events, and free camps. Stress management, drug de-addiction, lifestyle, coping skill awareness program at CRPF campus, Police Academy, various engineering colleges, DAV schools, and other schools at Bhubaneswar and Cuttack. Prestigious awards, National Seva Ratna Award 2018, Mother Teresa Award for contribution towards destitutes and wandering lunatics from successor of Mother Teresa, Sister Mary, Prema 2018. Shabuja Sangrami Award from Prema International Open Army. Award from Commissioner of Police, Bhubaneswar.
This was okay. Thank you, sir. Thank you, sir. This was okay, sir.
It was quite elaborate.
Hi, sir. Sorry, I given too much long.
Okay, last one. Odisha State Branch 2023 Gokul Chandrakar and Vishnu Priyadevi Memorial Award, the best psychiatrist of the year. With this, I introduce our chairpersons and the moderators. And from now onwards, the session is handed over to our esteemed chairpersons. Subhendu, you'll be introducing.
Yes, sir. Yes, sir.
Arun Kumar Pandey, the speaker.
Yes, sir. Good evening, everyone. Today, our speaker is Dr. Arun Kumar R. Pandey. He is the director of LEDTC Clinic, Gomti Nagar, the chief consultant and head of Department Endocrinology, Diabetes and Metabolism, Health City Bhistar, a 30-bedded multi-specialty hospital. Affiliation, Secretary, Diabetes Support Welfare Society, executive member of Lucknow Diabetes Society Study Society. The academic achievements like 76 publications, including a publication Lancet and Diabetology and Endocrinology. The Excellence Award, Young Researcher at the Annual Conference of the Indian Society of Cardiology, ISCCON, ISCON 2023. The Best Case Report at 30th A.V. Gandhi Awards for Young Endocrinologist. Padmakat Tripathi, Young Scientist Award of UPDA in the year 2019. First in Uttar Pradesh to use HealthPlix EMR for patients care. Thank you, sir. Welcome to our program. Over to Dr.
So
Akhil.
warm welcome to So
Dr.
warm
Agarwal,
welcome
please
to
introduce
all
the
our
topic,
audience.
please. Yeah.
Yes. So our today's topic is about erectile dysfunction, myths, facts, and management, and endocrinological perspective. As we all know that sexual medicine is a very emerging field for all the professionals. Previously, it was assumed that mainly all sexual disorders have some kind of psychiatric pathology or psychodynamics. But nowadays, because of personalities issue, because of lifestyle issues and secondary factors, now organic causes are emerging out. One of the most important is the diabetes, hypertension, lifestyle, alcohol, smoking, and obesity, and all. So now, as we all see that psychiatrists are the main core part of the sexual medicine, but same because of the emerging pathologies. Now, role of endocrinology is also very important because diabetes is a very important cause of erectile dysfunction at early age. No doubt, aging is important factor, but diabetes is main culprit in younger age. So, role of endocrinologist is very important to maintain blood sugar levels and hypertension all. So I welcome to our speaker, Dr. Arun Pandey sir. So please enlighten the topic, and I hope he will explain very well. Thank you and welcome.
Thank you, sir. Dr. Arun, you can start the screen share now.
I think Dr. Arun, आपकी आवाज नहीं आ रही है. There's some problem with the mic. Check करना please.
Yeah.
Now I can. Yeah. Now you can hear. Yes, please.
Sorry for that. Uh, so it's a privilege to be present amongst all the eminent psychiatrists of the country. And this is my disclaimer that I am an endocrinologist, so my talk would mainly focus around the endocrinological aspect. So, and I'll be presenting my talk would be in the three parts. In the initial part, there would be a study wherein we did for prevalence to know the prevalence of erectile dysfunction in diabetes. In between part is a review article which we are writing, which talks about various questions which various diabetologists or endocrinologists, when they practice and they see cases of erectile dysfunction, what are the doubts among them? These are the questions which I saw commonly people asking whenever I have a talk on this topic. And the later part would be a new data which is almost in publication, which be talking about when to give a daily low dose tadalafil over on-demand therapy. So like these are the two places where I work. This is one of the upcoming hospital in Lucknow, and this is my clinic. This is my team A of clinic, and like any like diabetes, even erectile dysfunction or any disorder, we require a team in order to have good outcome. अकेला चना भार नहीं फोड़ सकता, which is a saying in Hindi that so we require diabetologists, we require a dietitian, diabetic educator. We have a counseling psychologist also at our center, and this is a thing which we are being doing for last almost like 1.5 years. And what we have seen is that with the presence of a psychologist in our team, the outcomes of the patient or the satisfaction level of the patient has gone up. There are many things which as an endocrinologist difficult to pick up or difficult to give time, but the counseling psychologist comes there for a rescue and help us out in those situations. This is my team B. This is a multi-speciality hospital which has a lot of other specialties, like endocrine surgeon is there in our team, urologists who help us in various aspects of management of this. So this is my outline. I'll be introducing the topic definition, the prevalence of ED, then the question for the management of ED, which is many times there. Then a word about, there would be some studies about poor response to PD5 inhibitor. Then I'll conclude my talk. So if we see the definition of erectile dysfunction is consistent or recurrent inability for a man to attain or maintain pillar erection sufficient for sexual performance. this recurrent inability should be there for at least 3 months. But there are few exceptions out there, like if somebody has an history of trauma or post prostatectomy. These are the places we might not wait for 3 months to label them as having erectile dysfunction. These would be there. We can go make the diagnosis early. And if you see, this is very common. And as a responsible healthcare professional, endocrinologist, psychiatrist, even physician, general physician, they should know how to treat erectile dysfunction. It is quite prevalent, as I'll show in the slides, later slides. And up to 75% of men with diabetes, they will experience some degree of erectile dysfunction over the course of lifetime. So almost 3/4 of individual they'll see this thing as a problem. And in diabetes, it is most commonly due to organic cause. It is uh, it is associated with comorbidities like obesity, dyslipidemia, hypertension, hypogonadism, depression, and polypharmacies like drugs like beta blockers. And there are so many drugs which can cause erectile dysfunction. And when this culprit agents are removed, the outcomes become better. And it is also a complication of diabetes, and it is mediated to this three mechanism: neuropathy, microangiopathy, and macroangiopathy, which all leads to erectile dysfunction. If we see, erectile dysfunction is an area which we have been working for almost like 6-7 years now. So this was the initial study which we presented in American Diabetic Association, ADA, which is one of the prestigious conference in the area of diabetes. And what was this study all about? This was for 460 sexually active male above 80 years. And the primary outcome, the primary objective of this study was to assess the prevalence of ED in persons with type 2 diabetes. And secondary outcome was to assess the various parameters which were associated with ED. So I am sure we all must be aware of IEF, a scoring system to assess erectile dysfunction. And once one it is above this, the domain A, if it is less than 14, then individual are considered to having erectile dysfunction. So this questionnaire was not just used directly, we translated it. We followed all the rigorous method for translation, evaluation by 10 physicians, then filled in 5 volunteers. Then again, it was filled, this questionnaire was applied on individual who had ED, and then this revision was done for 5 times. And finally, after 5th revision, we got this questionnaire, which was back translated. And in this study, what we saw, which is quite evident, as the age increases, the prevalence of ED increases. So uh, it was around 27% individual who were between 31 to 40 years. But as the age increases above 60, almost half of the individual, they have erectile dysfunction. And if we see the age of onset of diabetes, as it increases, the prevalence of ED increases. It is like around 20% individuals who have age onset of diabetes between 18 to 30, but almost like 2/3 of individuals who have onset of diabetes after 60, they have erectile dysfunction. And other factors which are important is that any macrovascular complication. So macrovascular complication include CAD, coronary artery disease, CVA, which is cerebral vascular disease, and also peripheral vasculosis. Any macrovascular complication, it is associated with erectile dysfunction. And it is said that our Indian coronary arteries are around 5 to 6 mm in diameter, while the penile artery is around 3 mm in diameter. So the blockage of this artery becomes starts early, and it manifests almost 3 to 5 years before CAD. So if suppose somebody is having ED, organic ED, then they are at very high risk of CAD, and one should be very careful there. And the beta blocker use is a other thing which was associated with ED. One interesting thing which we found is that creatine, when it was raised, it was associated with ED. So this is an interesting finding, and this is consistent. I'll show, this is one of the first study which we did, but the last study which I'll show, which also shows the role of creatine. So that is an important thing. I want the audience to register right now that the creatinine is high, even in the normal ranges, the normal range is around 1.4, even in the normal ranges, then it is associated with ED. So if we see the prevalence in general is around 30 to 50% individuals who have diabetes. This number would be slightly lesser in non-diabetic individual, but still the prevalence is quite huge. It is almost similar to that of uh, diabetes probably. It would be around say to the tune of 10 to 15% in the general population. And it is associated with higher age, longer duration of diabetes, macrovascular complication, higher creatinine and beta blocker use. So this study was published around two years back, and it is fairly well cited study. So this was the first part of my talk, and what I have talked about is that the definition of erectile dysfunction, wherein it is recurrent inability of erection for almost 3 months, but there are some exceptions out there, post prostatectomy or post trauma. And the prevalence, if we see, it is almost like 30%, and it is associated with higher ages and those who have higher creatinine, macrovascular complication, and then there are other risk factors also there. So these are a few questions which comes in the mind of even not only in the mind of diabetologists or endocrinologists. To all patients with ED require in diabetes require endocrine workup. So if we see this is a recent study which got published a few months back, and what it assessed so many things out there, and what it found is that if you see the last line, lower testosterone level did not affect ED in men with normal testosterone level. So whereas DHEAS and serum estradiol were significantly associated with ED. So this, if you see, many times individual in diabetes, they can have low testosterone, but that doesn't mean that everyone require treatment. Many times they don't require treatment, just lifestyle management, and this testosterone will go up. So it is not just testosterone. There are other hormones which can be associated with ED. So this is one of the studies. And now this is a slide from the American College of Physician guidelines. If you see the third recommendation, what does it say is that the American College of Physicians does not recommend for or against routine use of blood test and hormone treatment in management of patient with erectile dysfunction. So if you see, the data is not that well convincing to go for hormonal evaluation for all individual who have erectile dysfunction. So, the guidelines, they say they are equivocal. So what would be the way out? The way out would be to see other things like if suppose somebody is having loss of libido, that is an important thing which suggests that they should undergo hormonal evaluation, and which is quite common in psychiatric illness. But many of the organic condition, they when they this individual who have diabetes, they come to us, they say that the desire is there but the erection is not there. So these are the individual, they would very less likely that they would require any hormonal evaluation. When there is the desire is lost, there is loss of libido, these are the individual who will require hormonal evaluation. If suppose they don't have early morning erection, these are the individuals, they will require hormonal evaluation. If suppose they have poor beard, other features to suggest that there is hormonal deficiency, or then if suppose the beard is low, is on the lower side, or if suppose somebody is going to examine the private parts, if suppose the testicular volume is low, these are the individual who will require hormonal evaluation, definitely require hormonal evaluation. Not all individual they will require hormonal evaluation. So if you see, this is a recent meta-analysis which was published in Frontiers in Endocrinology, fairly renowned journal, and what it showed is that those testosterone level could it was not associated with the erectile dysfunction. If you see that the diamond, it was crossing the unity, and the hazard ratio was was one- was from 0.1 to 25. So it was not significant. So testosterone low testosterone level in diabetes, many times it may not mean that this is because of low testosterone. One need to go again for second testing, maybe a good diet and exercise for 3 months, and then reevaluate. So when the testosterone level comes rock bottom, so suppose uh, uh, if we see in nanomoles per unit, nanomoles per liter unit, so usually the cutoff is 300 is around normal. Between 210 to 300, these are equilibrium. Definitely, they would not require any management. But if the testosterone level comes below 210, and if it comes below 210 for 2 times, then these are the individual, they will require further hormonal evaluation to see other tests. I'll show few slides later that how to go for hormone evaluation if suppose we are suspecting endocrine condition. So so we see the fact is that endocrine dysfunction accounts for a minority of cases, only 3% of cases. So this was a paper published in Urology Journal, and they showed that there's only 3% of individuals who presented to them with erectile dysfunction, they have endocrine conditions. Even the guidelines, they say that routine hormone testing may it is equivalent. One has to judge. And newer insight, what it shows that other hormones they might be associated with it. So a stepwise evaluation, maybe we should go for seeing hard important clinical points, loss of beer, or suppose the testicular volume is low, the desire is low, loss of libido is there. Here there would be an overlap. Many individuals who have psychiatric illness, they have this thing in common. So these are the places one need to go for hormonal evaluation. Not all individuals require hormonal evaluation. So there's this another thing. I had a chat with Dr. Aleem this morning, and I am sure that many of the psychiatrists, they would be proactively treating it, but such is not the case with many diabetologists, especially the busy diabetologists. There is this doubt in individuals that whether they should treat ED or not. So if we see, this is a meta-analysis which is fairly old. What it showed is that those individuals who were treated with PD5 inhibitor for ED as against those who were not, what it was seen is that the survival was, the Kaplan-Meier curve clearly showed that the survival was better in individuals who were treated with PD5 inhibitor as against not those who were not. So, and one interesting thing, this is there in the Canadian guideline. What they say is that uh, uh, men with diabetes appear to have lower rate of side effect with PD inhibitor than general population. This is believed to be due to altered vasomotor tone and other factors. So whenever in doubt whether to treat or not treat, if suppose there is no contraindications like unstable angina, untreated cardiac ischemia, concomitant use of nitrate, better to treat it. Why? Because the survival is better in those individuals who are treated with PDE5 inhibitor, and also the side effect profile, it is better in individuals who have diabetes as compared to those who don't have diabetes. So and the fact is that this PD5 inhibitor drug was initially developed for management of CED. So this all of individuals, they have forgotten that this was the primary role for which it was being developed. So PD5 inhibitor are fairly safe in stable individuals. Studies show that there is no increased cardiac risk. In fact, the survival and the cardiovascular event are lesser in individuals who are treated with PD5 inhibitor. Precaution is there. One should avoid in individuals who have unstable angina, untreated ischemia, or concomitant nitrate use. So this is an important thing. Message I want to give to the audience. If suppose in doubt whether to treat or not treat, see the if there is any contraindications. If no contraindication, better to treat it because you'll improve the survival of the individual. So there is this, those individuals who have not used PD5 inhibitor, in them this doubt is there, how effective are PD5 inhibitor. So, and why this is happening? Why? Because they are not using the drug properly. So it is if we see those individuals who are treated with PD5 inhibitor, the success rate is almost to the tune of 50 to 60%. And the poor success is because of these few factors here. So many of the drugs, they need to be given 1 hour to 2 hours before the physical contact. And it is many times difficult ki one has to take dinner with he has to wait for 1 hour, then take PD5 inhibitor, then wait again for 1 hour for the physical contact. So many times what I ask my patient is to, whenever there is a plan of sexual activity, take this drug 1 hour before the uh, dinner, especially the long acting ones. So they'll get the peak performance when the actual action of this drug is required. And one should know that duration of action. Like sildenafil is a drug which will have action for 5 to 6 hours, but there are other drugs which have longer duration of action. So drugs with longer duration action will prefer them in younger individual, while which have shorter duration of action will prefer them in the older individual. And also the maximum dose. Many times this 50 mg sildenafil is given, the dose is not increased to the maximum dose of 100. So maximum dose of sildenafil is around 100 mg. And the other spectrum is also that sometimes people might use the overdosing of this molecule, and they can come with the complication. And also one has to review the concomitant medications like beta blocker, they might have effect. And also when they have taken this drug, they require sexual stimulation. It is not that key, if suppose they have taken this molecule and immediately they would get erection, they will require some stimulation. And in India, we see almost like 1/4 of the drugs, they are counterfeit. So this is a problem, especially in this area. And it is very important to say that take this with water, not with milk. Many of them, they are obsessed with milk, to take milk at the night time. So this is a drug which we'll have to on purpose say to the patient it should be taken with clear water, no food, no alcohol. And if suppose one PD5 inhibitor is not effective, one should try other PD5 inhibitor. And if suppose there is no response, then this is also an indication one should go for hormonal evaluation. And it is not just PD5 inhibitor, other factors should be taken care of, like improving eating habit, having good salads and vegetables in their food, fruits. Then this is a very good time for implication of lifestyle changes, like asking them to avoid tobacco and alcohol. These people are more receptive as against those who come for other illness. And one should we should ask them to go for regular exercise and take the medication properly. So the area of caution for this is, if suppose there is history of MI or stroke or life-threatening arrhythmia in past 6 months, if there is untreated hypertension or hypotension, history of heart failure or unstable angina in the recent past, and concomitant administration of non-selective alpha blocker, which is very rarely used. So these are the drugs which are available. If we see sildenafil, tadalafil, vardenafil, even these are so many other things available. So in my practice, I use sildenafil, tadalafil, and avanafil many times. So there is no evidence of significant difference in efficacy and safety and tolerability of various amongst the PD5 inhibitor. But it is important to recognize patients who are using PD5 inhibitor and nitrates, that should not be given concomitantly. There is a risk of severe hypotension there. So if we see PD5 inhibitor are fairly effective agent, they give result in almost 50 to 60% of individual. It should be taken empty stomach. This is an important thing which one need to forward. And it is also that the maximum dose should be given for 4 to 6 attempts. It is not that once it is given for only once and there was no response, then one should stop the medication and say that this drug is not effective. It should be given at least for 4 to 6 attempts. Uh, and if suppose there is no response to on demand, then one can consider giving daily low dose tadalafil 5 mg. The vascular benefit of long-term PD5 inhibitor, it improves the endothelial function, benefiting both ED and cardiovascular health. So we have seen prevalence is around 30 to 40%. Not all individuals, they require endocrine evaluation. There are specific conditions wherein we'll go for endocrine evaluation. It is a fairly it has very fairly good success rate of around 50 to 60%. So now this is another question which happens, that use of this PDE5 inhibitor can cause priapism. And like one of the talks when I was giving in Allahabad, the chairperson there said he had an experience with this molecule with priapism. And when once in private, when I asked, he said that that patient had taken triple the dose. So it is important to note that these are the few slides which will help to bust the myth of priapism. If we see, this was the original paper which was published in NEGM, oral sildenafil treatment of erectile dysfunction. And what it showed is that if you see all the complications, there is no complication of priapism here. Headache was one of the most common, flushing, dyspepsia, rhinitis, visual disturbance, but none of them they reported of this almost 400 individuals that any of individual they had priapism. So now this is another uh, trial. What it showed is more than 3,700 individuals when they were receiving this, with total 1,631 year of exposure worldwide. No cases of priapism was reported when this molecule was used in uh, the recommended dose. So if we see the initial drug discovery and the long-term trials of the registries, they showed that priapism is not a problem. In fact, this was a beautiful article, which the title of this article is interesting. Are we overstating the risk of priapism with oral PD5 inhibitor? And this was a beautiful article. What they did is that they went to the US FDA adverse reporting system public dashboard, and they saw all the drugs which were causing priapism. And if we see, second generation antipsychotic was the most common, followed by trazodone. Then the fourth place was PD5 inhibitor. So in fact, it is not the first most common cause of priapism. It is the drugs which is used by the our psychiatry colleagues, antipsychotics. These are the drugs which is causing more priapism. What about the PubMed? All the reported case or the series is even in them, the second generation antipsychotic was the most common agent to cause priapism. And if we see, PD5 inhibitor is very late in the list. There are so many other drugs like alpha antagonist, first generation antipsychotic, neuroleptic, trazodone, SSRIs. These are associated with priapism, but not PD5 inhibitor. So if we see initial drug discovery trials, they never told about priapism. And even the USFDA patient reporting web dashboard is not showing that PD5 inhibitor is the most common cause. Even the PubMed review is not saying. So this is another interesting thing. So this is a case series of 7 individuals who had recurrent priapism. So what was these individuals were, they were having recurrent priapism, which was like one year it was 7 episode per week, and the duration of priapism was 3 hours, 12 hours. And in one cases it was sickle cell disease, others it was idiopathic, and they were managed by aspiration and other things before the when they reported to author. And what did the author did? They started them on daily PD5 inhibitor. And what was that? Uh, there was hardly any event in the follow-up. Even in the for the duration of follow-up from around 3 to 12 months, there were 2 cases who had priapism, and these were the individual who stopped the drug. So it is an interesting finding that priapism is not common side effect of PD5 inhibitor. In fact, this is the molecule which is used to manage recurrent priapism. So, and the mechanism, what they say is that there is unchecked cyclic GMP production in this individual who have recurrent priapism, and this giving this PD5 inhibitor, it takes care of this unchecked cyclic GMP production and reduces the recurrent priapism. So, if we see, priapism is exceedingly rare when this molecule is used in the recommended dose. What happens is many times when they take this molecule, they don't have the response. They have this uh, episodes of stress, they take again first, second tablet, then third tablet. These are the individuals there, the chances of priapism is there. If suppose we clearly mention, do not take this, say sildenafil more than 100 mg in a day, then usually the problem is not there. I have not seen any cases of priapism in my almost 7-8 years of practice. And if you see, it is more common with antipsychotic agent. Initial drug development trial for PD-5 inhibitor in erectile dysfunction did not report any case, and even the even long-term patient registries, in fact, it is used for management of recurrent priapism. So, so we have covered a few myths. Now, this is another important myth: can this PD-5 inhibitor be given in individuals who had cardiac event? So this is a fairly old trial, sildenafil in patient with cardiovascular disease. What this trial said is that on the basis of safety database comprising thousands of patients in men with ED, sildenafil had demonstrated minimal adverse effect in men with stable ischemia, hypertension, or or severe CAD. Sildenafil has modest effect on hemodynamic variables and has been shown to have increased coronary artery flow reserves. So when there is unstable angina, untreated hypertension, maybe proliferative retinopathy in case of individuals who have diabetes, these are the places one should avoid. Otherwise, 6 month post CAD event, one can use this molecule. So this is another trial. What it showed is that those individuals who had ischemic heart disease, those without ischemic heart disease, and what was seen is that MI rate was similar in those individuals who were on placebo and those who were on sildenafil. So the outcomes, the CAD event was not increased in individuals who were receiving sildenafil when they had ischemic heart disease. So this is an article from European Urology. If suppose we are having sexual inquiry with all men, and if the ED is confirmed, one should talk about the exercise ability. If they are exercising well, they say they are walking for 3-4 kilometers, then these individuals, they are at low risk and one can directly go for treatment with PD-5 inhibitor. If suppose there is high risk, there is chest pain on rest or on movement, they should go for cardiological evaluation. If that is indeterminate, then one should go for stress testing. If suppose there is no ischemia on exercise and on exertion, then they should go for management for with PD-5 inhibitor. If suppose there is high risk, then the cardiological evaluation is required. So this is an important slide wherein the uh, for management of individuals who have ischemic heart disease and when we are considering to start with PD-5 inhibitor. So if we see uh, ED precedes CED by 3 to 5 years, and it's an early warning sign. PD-5 inhibitors, it improves the endothelial function and reduces the arterial stiffness. And PD-5 inhibitor are used to lower mortality and reduce its use is linked to lower mortality and reduce MACE, as has been shown in this 2021 trial, and this is another trial by Thadani. What they showed that it was safe for individuals who are having moderate exertion. So key consideration, if suppose we are considering, is to avoid in individuals who have unstable angina, recent MI, say 6 months, or concurrent use of nitrate. Otherwise, it can be used safely. So, this is the second part of my talk. We have discussed about the prevalence of ED. It is quite prevalent, and few doubts which is there in the mind of practitioner when they are managing individuals with ED. So now this is the third part of my talk. We see there are so many trials out there which compares daily PD low dose tadalafil with on-demand therapy, but not much trial for responders or non-responder to categorize who will be responder and non-responder. So this is a study which was published last year involving 513 individual who had treatment failure group of 288 and 225 HMAT control. and uh, they are various characteristics like demographic, medical history, and HbA1c, testosterone, and other things. Mind you, in this trial, both individuals with diabetes and non-diabetics were also included, and so there was comparison between treatment failure and control responder group. And what was seen is that those individuals who had failure, they were of higher age, and the A1C level was higher, 8.5 as against 6.8 in the responders. The free testosterone level was lower as compared to the responder, and the SHBG levels were higher in individuals who had treatment failure. So a word about SHBG, it is called a hormone binding globulin. It is very difficult to measure free testosterone. It requires equilibrium dialysis method. But SHBG measurement of testosterone and SHBG can help us to calculate the free testosterone level, and it usually goes in it. It has an inverse relationship with the testosterone. If it is on the higher side, then usually the outcome is poor. So this is the only trial which I could find which talks about responders and non-responders. So this is a trial which is on in the press now. So which is assessing the clinical markers for requirement of daily PD-5 inhibitor against on-demand therapy in individuals who have type 2 diabetes, a retrospective analysis. We call this trial as ad hoc. You'll see why ad hoc. This is a mnemonic which will help us in our practice. So if suppose if you remember this, this will help you to choose where directly to start daily PD-5 inhibitor, and don't waste time in giving on demand. They won't respond to this. So this is a trial wherein 5,600 individuals who had ED related visit, who had diabetes related visit to a center, and of this 517 individuals, they had ED related visit. Of this 277 individuals, they reported ED on pre-consultation questionnaire. Of this 277, 81 they were excluded because of contraindication. They had endocrinological abnormality or lack of interest in PD-5 inhibitor. So this was a retrospective analysis of 196 individual. Uh, of this 196, 72 who did not respond to maximum dose of on-demand therapy, they were given daily 5 mg of tadalafil along with on-demand therapy. This was a retrospective study conducted between conducted in individuals who visited our center between 2022 October 2022. So there were total 196. Of this, 72 they were non-respondable. Clinical and biochemical parameters were collected from the EMR. So this is an interesting thing. Which was similar to that of the previous trial I'd showed. Those individuals who required daily PD-5 inhibitor, they were of higher age, almost 53, as against year 49. Each, then if creatinine was also statistically significant between the two groups, and the duration of diabetes was also higher in individuals who were requiring daily PD-5 inhibitor as against on demand. Age and creatinine, which is the determinant of EGFR. If you see, EGFR is usually calculated by putting age and creatinine, but EGFR was not statistically significant in between the two groups, even when that was measured by various other parameters. So this was for the continuous variable. Then on univariate and multivariate analysis, what was seen is that age, duration of diabetes, and creatinine. On again on multivariate analysis, obesity and A1C. So these were the 5 parameters ad hoc: age, duration of diabetes, HbA1c, obesity, and creatinine. These are the these were statistically significantly different in those individuals who are requiring daily PD-5 inhibitor as against on demand. This, I'll not bore you with the statistical methods which were used to derive this. So in practice, what one should do is, if suppose we see age more than 50, HbA1c more than 8.1, and if the creatinine is more than 0.9, these are the individual. And if suppose we take one more thing, if the duration of diabetes is more than 10 years, then these are the individual, they would very less likely respond to on-demand therapy. These would, they would require daily PD-5 inhibitor. Better to start directly with daily PD-5 inhibitor as against giving them on-demand, wait for a month or so or two, whenever is the follow-up, and adding to the agony or the stress of the patient, and see that now you have not responded to on-demand therapy, go on daily therapy. So this is a subgroup probably which should directly go and start with daily tadalafil, low dose tadalafil, and not wait for response or failure of on-demand therapy. And this is the heat map. What it shows is that the probability of requirement of a daily PD-5 inhibitor. If we see as the creatine goes on the upper side, as the age increases, this is those individuals who don't have obesity. And here the second graph heat map is those individuals who have obesity. If suppose if obesity is present and if creatinine is more than zero point 0.9 and age more than 50, almost like 100% of individual, they will require uh, daily PD inhibitor. It is very less, they are very less likely to respond to on-demand therapy. So if we see, this ad hoc parameters are important: older age, longer duration of diabetes, higher A1C, presence of obesity, and elevated creatine. If suppose they are present, these are the individuals, they may, there is higher chances of failure of on-demand therapy. Better go with the daily PD-5 inhibitor. So this is the summary. If we see, if suppose there is presence of sexual problem, if suppose no further evaluation required. If suppose yes, if it is erectile dysfunction, yes. If suppose no, then evaluate for other sexual dysfunctions. If suppose erectile dysfunction is there, then detailed medical, sexual, social, focused physical examination, laboratory screen. If suppose there would be few subset of individual who would at least minimum test required would be testosterone and prolactin. If that is abnormal, then hormonal clause is likely. There other tests like if suppose high prolactin is there, they would require pituitary imaging and so on. If suppose there is low testosterone, they'll require other hormones like LH, FSH, and here the testosterone therapy is required. If suppose there is some medical condition, one should treat the medical condition, modify the regimen. If suppose there is persistent ED, then I am sure you all will be managing psychological ED very well. If suppose there is no psychological cause, they usually have neurogenic or vasculogenic cause. Here they'll require a PD-5 inhibitor. To conclude, ED is a systemic health marker, not just a quality of life issue. Many myths are there among clinicians for effective management, and if suppose we can help a clinician to take care of this myth and use this molecule more proactively, probably will reduce to the agony of the patient. PD-5 inhibitor are safe, effective in the prescribed, if they are prescribed correctly in prescribed dose and if the proper methods are followed. Early intervention can improve the outcomes and prevent unnecessarily psychological distress. Thank you for your patient listening. Over to the organizers.
Thank you. Thank you, Dr. Arun. A wonderful presentation. Quite a bit of information. I think we are enlightened by your presence here. Thank you so much. Over to chairpersons for their opening remarks, and then we can move to the question answers.
Yeah. Dr. Suvendu, please. Then I would like to conclude. Dr. Suvendu? I think he's not here. So,
Yeah, I'm here.
Surendra is here.
Yeah, I'm here, but I was mute.
He was not able to unmute you. Make
Yeah,
co-host.
yeah. So thank you, Dr. Arun, sir. It was a very mind-blowing, actually, eye-opener for us, because when I came to know that when there is ED, there may be reverse chance of like coronary artery disease. From ED also you can diagnose. This is for me, I know for the first time. So many things you told. It was excellent talk. Then I can hand over to other chairperson if he can add anything.
yeah. Congratulations, Dr. Arun. I will conclude the topic. He very well explained the topic and very good key points like no routine hormonal investigation needed. Because what people do, if any patient comes with a psychiatric problem, they start prescribing all the hormonal tests. It's really not required in my clinical practice until and unless you have examined the patient having hypogonadism. So we should be means aware. And yes, PD5 inhibitors are basic of the treatment, and tadalafil is the most safe medicine because tadalafil having least interaction with the foods, means with the fatty foods, with alcohol, with any contraindications. It is well tolerated in the cardiac patient, nephro patient, liver, and all everything. Regarding the few questions, like I start with the 5 mg or 2.5 g is better. If patient not tolerate 5 mg, then go to with the 2.5 mg and start with the some like Dolo 650 mg tablet. You may start with that, and slowly by you may increase to 5 mg or 10 mg, depend on the need of the patient. It's highly safe. Yes, lifestyle modification is very important part in organic pathology. And nowadays, because sexual dysfunction is emerging, because diabetes is the means leading dysmorbidity, or we can say that India is the diabetic capital of the world. So same sexual problems are emerging, and yes, because sexual life is a core part of married life. When we says a person having good married life, they should have good sexual life, or a good sexual life, they have good married life. Thank you again. Thank you, Dr. Arun. Now I hand over mic to our organizers.
Yes, sir. Thank you, sir. We can have some questions on the chat box, and people can put their questions in the chat box for Dr. Arun to answer. So, Dr. Arun, first of all, a gist of your presentation overview. What is the take-home message that we should all think about here?
So I am sure you all would be asking about the sexual health. If suppose it is, and this is a problem in diabetology practice. Many of them, they are not asking of the sexual health. So first thing would be to ask about it. One thing which makes my life easier is that there is a pre-consultation questionnaire which we give to every patient and he has to fill. Many times they just tick it, the problem is there. Many times they leave it blank. So that gives me an idea that I have to talk about that. So first thing would be to ask about it. And if suppose erectile dysfunction is there, there are very few subset of individual they will require hormonal evaluation, and these are the individual who have hard clinical features like loss of beard, or if suppose they have low loss of libido or desire is not there, if the testicular volume is low, pubic hair is not developed, these are the individuals they'll require hormonal evaluation. When in doubt whether to treat or not, better to err on treatment side, because why? Many studies have shown that those individuals who are treated with PD5 inhibitor, they have better survival as compared to those who have not. And there are very few contraindication: unstable angina, recent MI, use of nitrate. These are the places one should not use it. And in diabetes, the side effect profile is lesser. So this is in few line.
So, Arun, what do you mean by hormonal evaluation and
So the minimum
workup?
test which would be required is a testosterone and a prolactin. So important point about testosterone is it should be done fasting, and the timing of the test is also important. It should be before 9:30. So testosterone has a diurnal variation. It is highest in the morning time. So it is not that if you are fasting at 1 p.m. in the afternoon and then one can go for testosterone evaluation, then the test would come low on the lower side. So it should be fasting and say before 9:30 or 10, and a prolactin. And this is I think a good platform to discuss about prolactin. Many of the drugs which is used by a psychiatric colleague, you all, and that raises prolactin. So I'm sure you all must be aware of aripiprazole. This is a drug which raises prolactin to the lesser extent, but it is not zero. And if suppose when in doubt, and if possible, stop all the drug for 72 hours and check the prolactin again. And usually the drug induced hyperprolactinuria will come to absolutely normal when this molecule is stopped for 72 hours. So a testosterone and prolactin is the minimum test which is required, and other tests can be decided based on these two reports.
Thank you. Thank you. Shobit.
Dr. Arun, I think a very lucid presentation you had made. I think you followed the principle where you, if you want to have audience take home message, you have to repeat the messages 3 to 4 times. That is what we got from your presentation, sir. The nitrates and all. My question is a very basic. A patient comes to our clinic, the whole chaos, and how we rule out specifically that patient is having psychogenic ED and organic ED. History and clinical examination and investigation wise, sir. Very crisply, sir, if you can tell us.
So this is a question I think you all will be answering very well. Many a times what we see in our practice is those individuals who have organic condition, and there would be some subtle markers like loss of desire. This is there both in the endocrinological and psychiatric condition both. So loss of desire is an important point which one should see. Then also early morning erections, psychogenic conditions, they will have early morning erection, while endocrinological condition or many organic condition they won't have early morning erections or nocturnal erections. So many times I see our psychiatric colleague, they do NPT, nocturnal penile tubulance test, to see to differentiate between this. So clinically there would be some features, this loss of desire, nocturnal erection or early morning erection. And if suppose we see on features of depression, many times in my clinic what I do is ask my counselor to fill up PHQ-9 and GAD-7 questionnaire to at least minimum evaluate whether they have depression or not. But here this can be confusing. Many times ED will cause depression, and the reverse is also true. Depression will also cause ED. So two important thing is loss of desire, and many of the times what I see is psychogenic ED, they might have good response to a PD-5 inhibitor.
So that is what, sir, there is single dose
Sir,
test. Many times, sir,
Yeah.
that has been given by you. So can you elaborate on that for the audience?
The single dose, this is I say 50 mg of sildenafil or maybe 10 mg of tadalafil. Many times when this is given, so tadalafil should be given 2 hours before the contact. If suppose we have this erection, then I am not aware of the single use test. If suppose, but I think what I can understand from you is this would be giving a single dose, and there would be erection say 1 hour after with sildenafil, and 2 hours after dose of tadalafil with tadalafil.
Okay, sir.
it is called as office sildenafil test, OST.
Yeah.
Office sildenafil test, so it is very common test. So we differentiate by the OST that it is psychogenic or it is organic cause.
So if patient has an erection, then we say it is psychogenic, right?
Yeah.
And
Can I
again, one more
interject here?
thing, that
Yeah.
history itself says that it is organic cause or psychogenic cause. Mostly we have to give time in the OPD. If we take proper history, it is very easy to differentiate that it is psychogenic or it may have some organic cause. And with few bare minimum tests like blood sugar, routine blood sugar, you take just BP, routine BP test, BP weight, and they are minimum tests. By that, we may easily differentiate. Yes, sir, Dr. Vishal, sir.
Yeah. So very nice, Dr. Arun. It was a very nice presentation. My thought is there was a time we used to say 90% of ED patients are psychogenic and only 10% are organic. But as time progressing, we are becoming diabetic capital. We are also hypertension capital. We don't know what all capitals we are. Is it things are changing? Do we really see a pure psychogenic now, or do we see actually really a combination of both things?
I
Much
think
more now.
it would be different. There would be a difference in the percentage of individual who will be visiting in my OPD as against yours. There, the proportion of psychogenic ED would be more in your OPD. Obviously, there is a referral bias there, and the reference to my OPD would be more of organic. So it would depend upon which setting we are practicing. In my setting, it would be organic more commoner, and I think you will all be better.
No, doctor. I'm saying,
Yeah.
do we see a combination? I'm
Yeah,
trying to
it
see
is.
like a combination of patient also having some organic component and plus mostly psychogenic or mostly because this is what I'm
I
trying to
think
understand.
many of the cases, a good proportion of individuals, they'll have combination of both psychogenic and organic. But PDE5 inhibitor takes care of both the things
Okay.
many times.
That's
So
great.
supposedly, sir,
Thank you.
now we have zeroed in that patient is having psychogenic ED. So
Yeah.
now if we want to give tadalafil on SOS basis and low dose tadalafil therapy, sir, what minimum to maximum dosages we can go with the duration you have mentioned, but I think sir,
Yeah.
for the repetition sake also,
So
and
yeah.
how long we can go about it, sir.
So usually, the on-demand therapy of tadalafil is given 10 to 20 mg. The maximum recommended is 20 mg. Like Dr. Akhil said, tadalafil is a very good molecule. Why? Because it has a long duration of action, so it is very a good option for younger individual. And also, it doesn't have any interference with meal for absorption. So here with sildenafil, it is very important not to take anything 1 hour before that and after that. But with tadalafil, that problem is not there. And usually 10 mg is that starting dose. One can go up to maximum 20 mg. If suppose there is no response with that, then usually 5 mg of tadalafil is given. And it is very important when we are starting with low dose informing the patient that it would require time. So it would take at least 3 to 6 months for many individuals to have response with low dose tadalafil. It is not that they'll have the response very next day. So if suppose there is no response after say 6 months, this is a time wherein we should see go beyond PD5 inhibitor. They will require some other form of therapy. It is less likely that they would respond to this molecule. And also one need to again reassess whether their diagnosis is right, whether they have some endocrine condition in their hand. These individuals are not responding to this.
Uh, Sir, many patients would complain of even in 2.5 milligram of tadalafil. They'll complain that they have heaviness of head, feel that they have sapped of the energy or some activation, restlessness. Then, sir, how to go about it?
So there are very few patients who have. I think there is one other. I one other thing which is available. I think Udenafil, which has long duration of action. I don't remember the thing. That is hardly required in my practice. So there, that can be tried. Mm, Otherwise, one can give with paracetamol this molecule. This headaches is usually for initial week. Thereafter, usually they tolerate this molecule well.
Okay, so
That
one
is
of the
very
questions.
common with the tadalafil or any PD5 inhibitor. Yes, tadalafil is very safe and easily tolerable medicine, but it is very common. Many patients having complained with the even 2.5 mg. So what
Can,
I suggest, I just prescribe 1.25 mg also. That half the tablet
Yes.
2.5 mg
Yeah.
plus
Yeah.
aid dolo, means simple paracetamol, few days. Then patient will start tolerating after 10 to 15 days. Then slowly increase to 2.5 mg, then 5 mg, and then so on.
Or boss, we can do it also. Like what I done, similar patients, thrice a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. That also works.
Yeah.
But just give it on the weekend to start with when you have more time.
Yeah,
You
this
know?
thrice a week is but what I can understand is that I hardly see this side effect as has been said in
Yeah.
the guideline. In individuals who have diabetes, the complications are lesser. I can remember patients on my finger whom I required to go back from 5 mg to 2.5, but many times 5 mg works in my practice.
So it is very common in my practice. Means people have
Uh,
problem with the typical headache, myalgia, pain in the thighs, backache.
We have more
So if
sensitive
the
patients,
patient
Dr.
having
Arun.
yeah, you have more sensitive patient, I think.
sir, any role of penile Doppler? Because there is one of the question in the chat box also. Because when we have asked for penile Dopplers, the reports have been unequivocal. So,
So.
any role of penile Doppler in ED, sir?
So this is again a test which is overstated and probably hindering the practice of sexuality or management of erectile dysfunction. This is not required in the practice many a times. There are very few cases wherein there is a leak, their venous leaks are there. These are the individuals will require Doppler. Otherwise, in routine practice, this penile Doppler is not required. Whenever we are suspecting leaks, then that is a place wherein we'll require it. Otherwise, no.
Sir, there is repeated questions, sir. Apomorphin, which would actually work with dopamine pathway. Sir, its role in ED or the sexual disorders, sir.
So when we go beyond this when we go beyond PD parameter, so there are apomorphine, then others like intraurethral alprostadil. These are the few options which are there in the practice, and in my practice I use them very less. But yes, these are definitely their options. I think you all might be having more experience with that molecule, and you all will be better person to answer that.
Sir, in my opinion, apomorphine is not a very good medicine. It's better to go with the PD5 inhibitor because PD5 are very highly safe medicine, while apomorphine have many contraindications, a lot of side effects, and again abuse potential and many things, and not freely available also. So it's better to go for PD5 inhibitor. It is best. In my practice, I never used apomorphine till date.
I think when the PD5 inhibitor failed, that is a catch 22 situation. There we have to look beyond this. Otherwise, I agree that PD5 inhibitor are one of the best molecule.
So in that case, I think alprostadil is better option, might be better option.
Dr. Nikhil,
How easily it is available, alprostadil?
Yes. Again, this is question, but I think it is available with the urologist because they do some procedures or might be. Means in my OPD, I never tried because touch wood abhi tak zarurat nahi padi.
Yeah, I was trying to find it out. So one preparation from Sun Pharma, it was costing $5,000. So it was very difficult to get it. And I asked with the pharma company if suppose they can make some pen-like thing, which is there with insulin, 10 unit ले लिया. So it was quite a huge amount of dose in that particular vial, and I asked if you can make this pen-like thing for this alprostadil, and then we can use in our practice, especially those individuals who are not responding to PD-5 And what they said is that the stability of this molecule is not that good, and they cannot make the pen-like thing for this thing. So I think life beyond PD5 inhibitor is very grim in my place of work. I'm not sure. I would like to get enlightened. What about what the house says about this thing?
I have a different. There are questions in the chat box. I think we can take that. But just one connection to when I'm connected to. Have you ever tried combination of PD5 inhibitors?
So sometimes what I do is give low dose tadalafil along with say on demand sildenafil. This is the combination which I use in my practice, not beyond this. And I think the response is good. And these are the usually older individual where I want not long duration of action, and usually the side effect is not there, not a problem.
Thank you. So let's take some chat questions on the chat. Shobit boss.
Yes, sir. Sir, I'm actually
Yes,
addressing.
please. Yes, please.
Sir, there is
Please
a
do.
question, interesting question. You already mentioned about the absence of priapism very validly because I also saw one priapism case that too on trazodone.
Yeah.
So very validly. So there is a question of non-arterial optic atrophy with the PD5 inhibitors. Whether you have come across any of those cases.
So this would be again rare, I think. Matlab, this if you see the initial drug development, these were not initial known side effects. This would be very rare. So maybe 1 in 1,000 or 1 in 1,000, 10,000 case like that.
And what about the tadalafil and depoxitin combination, sir?
We use that it lot in our practice, especially for those individuals who complain about premature ejaculation, and many times it work, many times it not. So we have to go beyond depoxitin for management of PME.
Is there something known as daily depoxitin form regime also, sir? Because I have seen urologists here giving that for PME, daily depoxitin.
I think there they are just trying to many of these individuals, they have psychiatric illness, you know better than me, and probably they are trying to manage that thing in this way probably. But depositin has a very short duration action. This might not be very effective when they are contemplating to give this. Probably longer acting agents would be a better choice there, I think.
And sir, do
I
you
will,
with certification
I
issues?
would like to add.
Yes, sir. Yes, sir.
Yeah.
Yes,
First
sir,
thing, as per my opinion, tadalafil depoxitin combination is not very good combination because person having premature ejaculation, then why to give tadalafil? And if the patient having ED problem, then why to give depoxetine? So it means I never prescribe the combination, first thing. Second, daily dose of depoxetine is not very good thought, as Dr. Arun said, because it is very rarely used in daily dose. It's better to give paroxetine or something else for the premature ejaculation. If patient not improving with the premature ejaculation and having side effect like decreased libido and same, because depoxetine is again same group of drug. So in that case, you may prescribe depoxetine for short time for daily dose. If a patient is showing with the paroxetine or with the fluoxetine or clomipram in that severe HSDD, then depoxetine may be an option for daily dose. Otherwise, depoxetine is for SOS use. It is better.
So this question is for both of you, sir, Arun Pandey sir and Akhil sir. Certification, because patients must be coming to certify them for ED to get in the cover for the litigations in the post-marriage scenarios. How to go about it, sir, from endocrinological perspective and psychiatric perspectives?
So we can give just
Dr. Arun.
negative thing that there's no clinical features to suggest uh, erectile dysfunction. So erectile dysfunction can be subjective, person dependent. So we can just give negative report. We cannot give the positive report there.
Sir, in my clinic, sometimes means female side they comes with the complaint of that person having ED. So I suggest simple semen analysis test. And semen analysis should be in presence of any staff. So if person is able to give semen, then patient is potent. So rule out the problem. It is very hard to give the, as Dr. Arun said, the patient is important. I never means give certificate because it is very difficult. We have to evaluate psychiatric point, malingering, organic cause, a lot of issues. So we may say that patient is potent when the complaining of important, but we should not say that it is important. And for that, at least you have to miss a group of doctors with the board only.
Sir, in continuation with this apomorphine only, sir, euhimbin. One question is about euhimbin and its usage.
Yes. Dr. Arun?
Don't use it in my practice. Simple answer.
There are
On
other.
depoxetine,
you-
any
Go ahead,
depoxetine have you used?
Depoxetine, we use it a lot. And I see many patients when they have ED, they also have this uh, when they also have this premature ejaculation. Definitely in those subset, I use this tadalafil with depoxetine, and this is usually for initial few months, and thereafter they'll just respond to PD5 inhibitor. But I think that subset of individual who have ED and they have this premature ejaculation, that definitely this is a useful combination.
The role of PD5 inhibitors for female sexual dysfunction.
So the other day I was listening to a talk from a person who was initially involved in development of this PD5 inhibitor, and they were very interested to use this thing in females, and FDA didn't give them approval for this. So this would be an off-label use. One can try, but this is not recommended.
So PD5 inhibitors, there are a lot of trials in the females, but no PD5 inhibitor is effective in female sexual dysfunction. Even people tried per vaginal also, ki one tablet orally per tablet per vaginally, but there is no use in the female sexual dysfunction till date.
What about all these?
And even in my clinical practice, I couldn't find any result.
There's so many nutraceuticals which claim for increasing both for the men and females, male and female. Lots of them now available in the market. Any use of them? Which a lot of arginine, horny goat, some other names, funny names. Lots of names are there. Any
I think only there is
utilization?
one drug which is approved, fibanserine, but it is not available in India, and it's very costly.
What is the name?
Fibanserine.
Fibanserine.
Yeah.
So you're saying it's a placebo kind of a thing.
Rest all are placebo.
Regarding the
Costly.
use of, as you say, L-arginine, coenzyme Q10, someone asked about CoQ10, L-arginine or horny goat, Macao roots, and there are a lot of pharmaceuticals. So what I feel is, yes, CoQ10, L-carnitine, L-arginine, they have mild use because L-arginine ultimately increase blood flow and nitric oxide production. Same with the CoQ10 and L-carnitine. They basically they are for tiredness, fatigue more towards this, but not specifically for sexual dysfunction. Another thing, when patient comes to you, it's very hard to explain the patient that only PD5 inhibitor will be effective. So these are more psychological rather than real work. And again, the use depends on the pocket of the patient. But other herbs, because we are not from the same field, we don't know about the pharmacokinetic, pharmacodynamics and all. So I can't say. But yes, we may prescribe L-arginine or CoQ10 or L-carnitine for some time, because at least they will improve the physical health and attentiveness and other things. But not for the means they do with something like PD5 inhibitors.
Sir, a word about avanafil, sir. You said avanafil you are using, sir. We have not used. We are using tacitafil, tetlafil. So can you prime us with this new one, sir? Advantages and how to
It
dose
is
it?
fairly similar to that of, I think, sildenafil. Well, not much difference there. So,
The only advantage of avanafil is the patient may be ready within 10 minutes.
yeah,
The onset is
Only
fast.
advantage.
only
Yes.
advantage.
Other than no advantage, even side effects are more than tadalafil.
Oh,
I think
there's a question on have you used the films that are available like PD5 inhibitors in S film and T film? Dr. Amrit sir has asked. Have you used them? And if you use them, any experience? Is it better,
So what
faster acting?
I use many times this sildenafil powder which is available, and I feel that the absorption problem is not that much, but I have not used film in my practice.
Okay.
Even I also not use, and I feel tablet is much better, because with the film many issues are there. So it is always better to go with the tablet.
Okay. Okay.
very clearly answered questions. Thank you, Dr. Arun, sir.
Thank you. Yeah.
I think we have covered all the questions in the chat box.
Yes,
There's
almost.
one
Yeah.
question I think which is more pertaining to endocrinologists. Are all beta blockers or any specific one? So I think bisoprolol, this is if suppose somebody is on metoprolol or atenolol or something like that, and if suppose we can shift to bisoprolol, then the outcomes could be better, because this metoprolol and other drugs they are more associated with bisoprolol is fairly safer in this area.
Okay, so I think we have covered
Yeah.
all the angles now.
Yes, we have.
So a lot of myths have been cleared, Arun. Thank you for that. We can safely use PD5 inhibitors, and they are good medications to have. In fact, you said that survival is also better in some cases.
There is good follow-up study, long-term follow-up study, not just cases. There's good randomized trial also there.
Okay. Okay. So to the chairpersons, any concluding remarks, and then we go to thanks.
So Endu, please.
Okay, excellent talk, Dr. Arun sir, and thank you for accepting our invitation or coming to the Thursday musings. That's my take.
Thank you, Shivendu.
I would like to conclude that PD5 inhibitors are very safe. Don't hesitate to use in your clinical practice, because many doctors think it's not good, should we prescribe or not. So highly safe medicine, and I would say that tadalafil is the most safe, even no effect with the alcohol or any other drug. And again, thank you, Dr. Arun, and thank you, organizing team. Thank you very much.
Thank you. Thank you, sir. Tofan, sir, over to you, and you have to say thanks because Amrit is in flight.
You're always in flight.
He's in flight mode.
Thank you very much. Excellent talk by Dr. Arun Pandey. He has encouraged everyone to use tadalafil or sildenafil or any other PD5 inhibitor, and has taken away some inhibitions if it was with anyone. But my personal experience with PD5 inhibitor, no priapism till date. I'm practicing sildenafil since it was brought last during one of the ANSIF cell in Bhubaneswar. no priapism, but people are tend to accept it perfectly. We don't believe that because villagers don't take it like that. They have got many other Ayurvedic programs. And there is a times endocrine link, like thyroidism, not only diabetes, which makes it complicated, but PD5 inhibitors are safe, though not absolutely safe, quite safe. Thank you very much, Dr. Arun.
Yes, sir.
Thank you very much, Dr. Agrawal, and thank you, Subendu, for the rich inputs. And with this, I thank our vibrant moderators. One is in air, Dr. Amit Patadose. And
Thank you. I think we also should thank Torrent, our
I
whose
thank
platform we are
Torrent, the
using. On the
sponsors.
audience, I think we have around 200 plus logins,
Yeah.
188 peak audience today we had. So we had around
Yes.
2 to 10 logins were there. So Arun, your topic is hot cake and you are a celebrity with us. Thank you. Thank you so much for taking out time with us. Thank you, Tufan sir, Akhil bhai, Suvendu, and Shobhit and Vishal. Thank you. Ending the meeting with your
Bye-bye.
permission, sir.
Thank
Good
you.
night.
Thank you.
Thank you.
Good night.
Thank you.
Bye-bye.
Thank
Good
you.
night,
Thank you,
everyone.
It
Manana.
was a
Thank you so much.
pleasure.
Bye-bye.
Bye, sir.
Thank
Thank
you.